Please go
Yeah,
ahead.
thank you. Thank you. So, sorry for the break. I think it was from your end. So, in conclusion, the previous slide before this one just showed just spoke to the specific words that was spoken to by the health workers. So, this is the conclusion. The quality and quantity of maternal and child healthcare services were greatly affected during the lockdown. This is due to COVID-19 um, pandemic and 2020, which resulted to poor access and healthcare. So there is their need for structured responses for initiation of telemedicine and medical services in Nigeria, and the need to use robotic technology for healthcare. With this, we can improve healthcare services in case we have another form of disease in future, which we all pray that it won't happen. So thank you for listening. Thank you so much. Thank you for your time.
Thank you very much, Dr. Oluwayemisi Adegboye. A round of applause for her, please. Thank you so very much. All righty. So I have somebody assisting me here, so I will give her the opportunity to carry out her function. Dr. Ufoma Edewo, the rapporteur, will give us a brief summary of the presentation.
Good afternoon, everyone. We just had a presentation
Good afternoon.
from Dr. Oluwayemisi Adegboye. Her topic was the effects of COVID-19 on maternal, neonatal, and child healthcare utilization in Kwara State. This research was sponsored by MWAN. She introduced SARS, the severe acute respiratory syndrome, as a novel coronavirus 2, known as COVID-19, which emerged as a deadly global pandemic. During the lockdown, key vulnerable groups had poor access to health care, and these were women, newborn, and children. The aim of this research was to assess the impact of COVID-19 on utilization of healthcare services by women, newborn, and children, and compare the trends before and after the pandemic. The results of the research showed access to healthcare was poor during the lockdown, mainly between the months of April, May, and July in 2020. There was reduced antenatal visits, there was reduced access to immunization, and there was reduced access to family planning services. The results identified the fear of contracting the virus by both patients and healthcare workers, and also a reduction in hospital visits and reduction in service provision. She concluded by saying the quality of maternal and child healthcare services were greatly affected during the lockdown. This was due to the COVID-19 pandemic in the year 2020, resulting in poor access to care, and recommended the need for telemedicine medical services and use of robotic technology for healthcare delivery in Nigeria to improve on our service delivery. Thank you.
Thank you very much, Dr. Edewo. I think she deserves a round of applause for that succinct summary. All right. So I will go on now to take any questions, either from the online participants or those of us physically present here. If you have any question for the presenter, you can indicate by a show of hands. Those online too can raise the digital hand, and we will open up the mic for them to speak. While we are, okay. Yes.
Thank you, the chair. The presenter from Milori, I hope you are still with us. In your routine and
Yes, ma'am.
very good. Well done. We enjoyed it. In your routine
Thank you, ma'am. Thank you, ma'am.
in your routine antenatal care service, do you
Yes,
have
ma'am.
a phone number that your patient can routinely call 24/7 before we start talking about telemedicine?
Not yet, ma'am. Not
Okay.
yet, ma'am.
Let me recommend to you
Yes,
you,
ma'am.
you should be able to have a phone number that your
Okay.
antenatal patients can access 24/7, because
Okay, ma'am.
pregnancy doesn't last forever. So you should give
Yes,
them
ma'am.
the maximum care during those 9 months. I'm using our
Okay, ma'am.
example because we care for sickle cell patients and in hematology, and you know they
Yes.
can go into crisis at any time. So
Yes, ma'am.
in UCH, there is a dedicated number which the residents can pick at any time of the day. So please,
Okay, ma'am.
let's start some, basic things so that we can cope with any crisis, like a lockdown. Thank
All
you.
right, ma'am. Thank you so much, ma'am. Thank you, ma'am.
Thank you very much for that question and comment. I think it was more of a comment. All right, I heard that somebody online. There's a digital hand up. Is that hand a new hand or a still hand? There's a hand that has been on forever. Is it fresh or still? Um, Owo Juyibe, Temi Lola, are you planning to ask a question? Okay. Any questions in the hall? Okay. So it looks like people in the hall understood everything you had to say about COVID.
Thank you, ma'am.
That's what we usually say. When there are no questions, it says, means people understood everything. Or nothing. I think we understood everything. All right. So
All
we're
right.
supposed to have 4 presenters. I don't know if there is
Thank
anybody
you,
else.
ma'am.
You're very welcome, doctor. Thank you for that lovely presentation.
Yes, ma'am.
Yeah.
Thank you, ma'am.
Okay. Looks like a short session. Are you? You're a presenter. Okay, please come up. Yes. Yeah, we had to take the questions from that presenter because nobody else was around. But now we have. Can we have all the presenters come up? If the other presenters are present now. Okay. All right. Dr. Isao is actually supposed to be for the next session. So we'll just wait for the scientific committee to clarify some issues. Okay. Yeah, yes, please, go ahead. Okay. It would look like this particular session has finished, and we are going in straight away to the next session. So I yield to MC to call up the others.
Thank you, Dr. Edewo. Please put your hands together for her. I want to invite the rapporteur for the 4th scientific session in the person of Dr. Tiema Akpabio. She's a consultant internal medicine physician at UUTH, Uyo, University of Uyo Teaching Hospital, Uyo, and she's a former Youth Forum Coordinator for MWAN Akwa Ibom State. Put your hands together for her, please. The presenters for this fourth scientific session are, and as I call you, please can you come forward, Dr. L.I. Ewe Putana, Dr. L.I. Ewe Putana, Dr. M.O. Agoyi, Dr. O.A. Badru, and Dr. O.T. Esson. Thank you very much.
Okay, thank you very much. It looks like we have only 2 presenters here, and I've been informed that none online. All right. All right. So we'll start off this session quickly by calling on Dr. O.A. Badru, who's going to talk to us on prevalence and correlates of emotional disorders among pregnant women in polygynous versus monogamous settings. Dr. Badru, please come up. Thank you. Round of applause. Let's encourage her, please.
Good afternoon. The title of my presentation is Prevalence and Correlates of Emotional Disorders Among Pregnant Women in Polygynous versus Monogamous Settings. Next slide, please. Next slide, please. There are equivocal reports about levels of emotional disorders and its association with polygyny. Some have reported that mental health of women is actually jeopardized in polygyny, while some other studies have enumerated positive effects, such as ability to work outside the home with opportunity to gain more wealth and sharing of responsibilities among co-wives. But be that as it may, the specific sociocultural environment actually determines how it is perceived and its subsequent impact. From the picture above, we see a man and his wife. We see another man with his wives, and both seems to be happy. Next slide. The objectives are to compare emotional disorders among pregnant women in polygynous versus monogamous setting to determine the prevalence of these emotional disorders, as well as to ascertain the correlates of emotional disorders in both marital settings. Next slide. Ethical approval was obtained from the Oyo State Ethical Review Committee. It was a comparative questionnaire study of 67 women in each of the settings, making a total of 134. Respondents completed socio-demographic questionnaire, the 12-item general health questionnaire to measure psychological distress, Rosenberg self-esteem scale to measure low self-esteem, and hospital anxiety depression scale to measure anxiety and depression. Data were analyzed using discrete statistics, chi-square, features exact test, and logistic regression at p less than or equal to 0.05. Next slide. The results are there on the board. We can see in the figure, blue represents polygamy, while red represents monogamy. For the GHQ that measures psychological distress, we can see that 41.8% was the prevalence for psychological distress among women in monogamy, while 32.8% was the prevalence among women in polygamy. The other results are shown for low self-esteem, for anxiety, and for depression. The correlates were for polygyny, participation in social activities, The previous one. Okay. Participation in social activities, pregnancy-related hospital admission in index pregnancy, support from family in index pregnancy were correlates for polygyny, while for monogamy, previous history of prolonged labor was correlated with psychological distress. For low self-esteem, gestational age of less than or equal to 26 weeks and pregnancy-related hospital admission in index pregnancy was associated. For anxiety, women who had first position in polygamous setting, where the position as a first wife was correlated with anxiety. No correlation was found for depression. Next slide. The determinants were women with history of pregnancy-related hospital admission in index pregnancy were about 5 times more likely to have psychological distress, while women who participated in social activities were 70% less likely to have psychological distress. Previous history of prolonged labor, women who had previous history of prolonged labor were 6 times more predisposed to have psychological distress. Next slide. Discussion. We can see that there was actually a reversal of prevalence compared with previous studies. Previous studies actually reported that emotional problems were actually more common among women in polygamy, but we had a reversal here. The reason why we found this was perhaps due to the socio-cultural setting where the study was carried out. Because the socio-cultural setting will determine how it is perceived and the subsequent impact on their mental health. The study was carried out in the southwest Nigeria, where we think at least polygamy is relatively acceptable. For psychological distress, participation in social activities actually ameliorate psychological distress. So it was not surprising that those who actually participated in social activities had lower psychological distress. Similarly with family support, those who were supported by their families, such women were low. They felt better with respect to psychological distress. While previous history of prolonged labor, was actually a stressor. Those who had that history, actually more of them came down with psychological distress. For low self-esteem, gestational age of less than early gestational age. This could be because the women were yet to come to terms with being pregnant. So they had issues. It was a stressor for them. That was why they had low self-esteem. Similarly, those who had pregnancy-related hospital admission, because of the frequent admission, it was a stressor, which actually might have lowered their self-esteem. For depression, though it was not significant, but it is worthy of note that those who actually participated in religious activities were the ones who were more depressed. Why? Religion is supposed to sort of serve as a sort of a factor that promotes mental health. So we can therefore say that actually, perhaps these women were already depressed and were just seeking treatment with their participation, with their attendance. You understand? And with their attendance at these religious gatherings, or because they were more willing to accept their symptoms and they were more willing to volunteer it. And besides, attendance at religious activity is not the same thing as spirituality. Spirituality actually means that you believe that there's a supreme being that is giving you guidance, that is giving you comfort. It's not everybody that actually attends these religious activities that actually has that belief. They may just be people who were just merely going. So this could actually sort of give us the reason why those who actually participate in religious activities had more of depression. Then for anxiety, women who were first wives in the polygamous setting, they were more anxious. Perhaps because they had enjoyed the attention of their husband before other women came. So they felt more threatened, they felt more on edge. So that was what I found. The limitation was, we use self-report instrument. It was subject to recall bias. Some may not be willing to give information, some might have forgotten. So in conclusion, prevalence of psychological distress, anxiety, and depression was higher among women in monogamy, while prevalence of low self-esteem was higher among women in polygyny. Correlates identified were participation in social activities, pregnancy-related hospital admission in index pregnancy, support from family index pregnancy, history of prolonged labor, pregnancy-related hospital admission, and first position in polygamous setting. Overall, there is no marriage type that actually confers protection of pregnant women against emotional disorders in pregnancy. Thank you. The next slide that the reference.
Thank you very much. Another round of applause for her. Okay, we will note our questions and ask at the end of the session. We will take the next presenter now, Dr. Esson. Dr. O.T. Esson, who's going to talk to us on qualitative inquiry into pregnant women's perceptions of respectful maternity care during childbirth in Ibadan metropolis, Nigeria. Dr. Esson.
Thank you. Good evening, everyone. I'll be presenting the title, A Qualitative Inquiry into Pregnant Women's Perceptions of Respectful Maternity Care during childbirth in Ibadan metropolis, Nigeria. And these are the authors and their centers, affiliates. Thank you. Next slide. Respectful maternity care has been defined by the World Health Organization as care that is organized for and provided to all women in a manner that maintains their dignity, privacy, and confidentiality, such that ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childbirth. It's a fundamental human right of women during childbirth, and is a global priority that contributes to the overall, previous slide, is a global priority that contributes to the overall quality of childbirth care experience. And it can be the missing link between to ensure continuous utilization of health facilities and the benefits that can follow that. Next slide. So these are 12 domains of respectful maternity care as defined by Shakibazade et al. I'm still going to be referring to this, so I'm not going to stay too long on this 12 the domains. Thank you. Next slide. So as a statement of problem, the previous slide, a positive childbirth experience is having control of women's birth process. Women who have been interviewed to describe their experience during birth describe a positive experience when they have autonomy, when they're able to decipher what they want and what they know, and their choices are respected. Respectful maternity care gives a positive childbirth experience, while disrespectful and abusive childbirth care gives negative experience. Negative childbirth experiences may affect a woman's health, her well-being long after childbirth. Some women have even been reported to have PTSD and all sorts of emotional disorders like she had presented following childbirth because of the negative childbirth experiences. And this affects their future, reproductive health decisions, especially choices of where they would prefer to deliver. So women's positive perceptions of birth should equate a respectful maternity care as globally defined. Women's perceptions of RMC is critical to its measurements globally. So which means you may interview women. Women may feel they have a positive experience, but the experiences they have do not really correlate with what is defined as what they should receive if they have received a respectful maternity care. And that is what we wanted to check. Women's perceptions and expectations of respectful maternity care number one, it has been less studied, especially amongst women in low resource settings such as Nigeria. Thank you. Next slide. So health workers' attitudes influence women's health-seeking behavior. Poor health-seeking behavior may imply non-health facility delivery with the sequelae of maternal and fetal complications and death. Increased accessibility to unsafe, low-quality, and abusive care, it defeats the universal health coverage and sustainable development goals. The world bodies have called that we need to emphasize women's rights, that we need to make health systems more accountable to them, and we need to support health systems to focus on respectful maternity-driven quality care. And that is what we hope to achieve in this study. Next slide. So our aim was to the study investigated Nigerian pregnant women's perceptions about RMC and how this related to the globally defined RMC domains. A cross-sectional exploratory qualitative study was conducted in one primary and one secondary health facility in each of the Ibadan Northwest and Southwest local government areas in Oyo State among homogeneous groups of primary gravida and multigravida booked pregnant women attending ANC at these facilities. 8 focus group discussions were conducted, and health facilities were selected based on the volume of their clientele. Respondents selected by convenience sampling. The data was collected using a pre-tested FGD guide. And yeah, okay, next slide. Yes, they were conducted, and all of this thematic analysis was done using the end result software, and ethical approvals were obtained. Next slide. So, the results. There were 12 domains. Of the 12 domains, 7 domains were correlated with women's perspective of respect maternity care. The women were asked, what do you think is respect during childbirth? And what would you think is respect for maternity care during childbirth? Based on what they feel, what they expect. 7 of these domains correlated with the women's perceptions. 4 totally deviated, and women did not count one of the domains as what is necessary to be able to provide for them respectful maternity care. So we're now going through the domains. Next slide. First domain, preserving women's dignity. This means that there must be positive labor ward atmosphere, make the woman feel comfortable, and all of this. Women's perceptions on this were, it correlated with women's perceptions, but there were some mixed feelings. Some women feel that some women deserve to be beaten, they deserve to be hit during childbirth because they are not cooperative with the health. Sorry, I think I've mixed the result. Sorry. Preserving women's dignity. Sorry. Mixed feelings because of illegal detention. What does this mean? According to respectful maternity care, women who are not able to pay their delivery bills should be allowed to go home. They should not be detained illegally. You have to reach a consensus with them to decipher when they want to pay. But women who we interviewed felt that may not be fair to the health facility. So that was a mix. Providing equitable maternal care means providing available services regardless of their age, ethnicity, sexuality, and religion. And their perceptions were similar to this. The third, engaging with effective communication. This means you should give verbal praise and encouragement, provide emotional support, talk and listen to the women, show empathy, and the women's perceptions correlated with that. Preserving the women's dignity. That means there should be all of this positive labor ward atmosphere. Sorry, the next slide. Provision of efficient and effective care. That means there must be prompt attention, no delay, and there should be reduced procedural, too much medicalization, reduced vaginal examination and all that. The women's perceptions were similar to this. Availability of competent and motivated staff. Yes, there should be all of these with supportive care. Women's perceptions were similar to this. Continuity of care. That means there must not be an abandonment of care. And women's perceptions were similar to this. Being free from harm and mistreatment. That means there must be no shouting, there must be no physical or verbal abuse of the women. And this were also similar to the majority of the women had the same perception. But some felt that some women need to be beaten, that they need to be slapped. Some even believe that by slapping them is for their own good. The next slide. Okay? Maintaining privacy and confidentiality. The domains I want to speak to now are domains that women's perceptions totally deviated from. The women felt that they do need privacy during childbirth. That is not so important. It's because the pregnancy labor has not got to the peak. That's why I'm talking about privacy. Providing information and getting informed consent. The women were satisfied with just giving them information. Lie down, want to do your BP check. They don't need permission to go ahead to do it. Madam wants to cut your vagina, episiotomy. They don't need permission before they are given that. Ensuring continuous access to family support. According to respectful maternity care, every woman should have a birth companion sitting by her side, rubbing her back. Because it has been found that with a birth companion, there is reduced labor pain. The women said they don't need it for different reasons. If they even want it at all, they only want to show the man pepper. Respecting women's choices that strengthens their capability to give birth. It means respecting the woman's decision on birth position. Respectful maternity care says if your woman wants to deliver squatting, she should be allowed to deliver that way. Hello, sir. Please. Last one, if she wants to take oral fluid, she should be respected. And if she wants to move about during labor, her perception should be respected. But the women feel that, no, they should leave all those decisions to the healthcare provider. And the last one, last slide, next slide. Enhancing quality of physical environment and resources. This is one of the critical components of RMC, but the women didn't even think about it. They didn't think providing comfortable environment is part of giving them a respectful maternal care. Next slide. Sorry. Conclusion, sir. Women's perceptions of RMC must align with global norms, for an effective RMC implementation. If we are saying we need to promote RMC, but the women themselves are not even expectant, then it becomes a problem implementing it. The RMC perceptions of the women's study deviated significantly, at least for 4 of them, from the globally defined norms. Local interpretations of RMC may be influenced by their cultural practices and their societal norms in different settings. Additional research is needed to explore how and to what extent these cultural practices and societal norms influence the woman's interpretations of respectful maternity care. Nonetheless, irrespective of the women's perceptions or expectations, pregnant women's human rights, represented by the emerging norms of RMC, need always to be upheld by the health providers. Thank you very much. I acknowledge my sponsors and my co-facilitators, my family and friends, and every pregnant woman who must always be heard and respected. Thank you. The references.
Thank you very much, Dr. Esson. Thank you so much for that lucid presentation. Right. So we will take the summaries now before we go into questions. So please note your questions down. I will hand over the rapporteur, Dr. Akwabio, please.
Thank you. The chairman. The first presentation was on the prevalence and correlates of emotional disorders among pregnant women. And the presenting author was Dr. Badru Olami Abiodun. She gave a background of emotional disorders, which are seen to be prevalent among pregnant women. And the objective was to compare polygamous marriages and monogamous marriages. In the methods, she used a comparative cross-sectional study. She had 134 pregnant women, 64 in each category, 64 monogamous setting, and 64 in polygamous setting. And the results, she found more of the emotional disorders in monogamous relationships. And the determinants, she mentioned social participation, pregnancy-related hospital admissions, participation in religious activities, and the position of the wife. The discussion and conclusion, she mentioned that there was a reversal of prevalence of these emotional disorders, which were seen to be more in polygamy, but are now more common in monogamy. And she said this was probably due to the setting of the study, which was in southwest Nigeria. And she also mentioned that depression was common with participation in religious activities, whereas participation in religious activities is seen to be beneficial to mental health. And there was also what she proposed could be that they were already depressed before participating in religious activities. Also, anxiety caused by the wife's position. The first wife was more threatened and therefore more anxious. Also, low self-esteem was commoner in polygamy, and all others were commoner in monogamy. In conclusion, she said the marriage type does not confer any protection for emotional disorders. The second presentation was on a qualitative inquiry into pregnant women's perception of respectful maternity care during childbirth in Ibadan, Metropolis, Nigeria. The presenter was Dr. Eshan Oluwaseun. Background, she talked about respectful maternity care, which is a fundamental human right, and that there were 12 domains. And she stated a problem, which was that a positive childbirth process is the patient or the woman having control of the birth process, and having a positive or negative experience could impact on the woman's further healthcare needs and behavior. Negative experience also affects future health decision, and she justified this study by saying that health workers' attitudes influence women's health-seeking behavior. The method was a cross-sectional exploratory qualitative study, was done in one primary and one secondary health facility in IBADAN, Northwest and Southwest. The results, she stated that 7 domains correlated. She had 50 women, 26 primigravida, 24 multigravida, and they were in the age range of 17 to 41 years. There were 12 domains. The first domain, preserving women's dignity, got mixed reaction. Some women were for and some women were against. Providing equitable maternal care, correlated. Engaging effective communication, correlated. Efficient care, correlated. Availability of staff, correlated. Continuity of care, correlated. Free from harm, make sure the patient is free from harm, had few correlation, and some other women normalized the disrespect. Privacy and confidentiality significantly deviated. Informed consent also deviated. Some saw it as not necessary. Continuous access to family support deviated. Some saw it as not necessary as well. Respecting women's choices deviated. Enhancing the environment also had no reaction. In conclusion, she said that women's perception must align with the global norm for effective implementation, and also more research is needed in this area. And as a whole, pregnant women's rights should always be upheld. Thank you.
Thank you very much. All right. So we've heard from these presenters, and we've had a summary of their presentations. We will then go ahead to take questions and comments at this time. I've also been informed that one of the speakers from the last session is available, so perhaps we would be able to take our own presentations. While she's getting ready to do that, let's go ahead and take questions for these presenters or comments. If you're online and you wish to ask a question, you can raise a digital hand and we'll call on you. Yes, ma'am.
Thank you, the chair. I think this session should interest all of us because it touches a lot on our social, marital, and reproductive issues. The first speaker, for Dr. Badru, right? Yes. What is your definition of monogamy? You know, men are getting wiser. They will say for better, for worse, right? And they know that when they say that, if they now bring in a second or third wife, there will be trouble. Why do I say they are getting wiser? They will keep the first wife at home. You won't know what is happening outside. So why won't that one, supposedly in a monogamous relationship, why won't she be unhappy compared to somebody who knows she's in a polygamous society? I hope I'm making some sense to you. So you have to define monogamy in our current setting. Then, Dr. Badru, I don't know if you looked at the income of the husband in a polygamous setting versus the income in a monogamous setting. You know, many women will tell you they are happy even if they are in a polygamous relationship as long as the man maintains them. Am I communicating? So I wish you had looked at the income. To the second presenter, Dr. Esson, illegal detention. Let me appeal that all obstetricians should make any management stop this practice. I was once asked to go and audit a hospital outside Ibadan. Vis-a-vis everything they do. We spent 3 days to do it. There was one woman, she had twins, the husband couldn't pay. They detained her. They seized the husband's motorcycle, which he could have used to make money. I don't understand. I think this practice must stop. Such women, have you even looked at whether that tipped them into depression? Okay? Another example, a different hospital detained a woman that couldn't pay and allowed somebody who should still be retained for complete care. You say you didn't have enough bed. Meanwhile, you said the one who couldn't pay should stay and occupy a bed that you could have given to somebody that needed more care. So please, obstetrician, this practice must stop. Thank you.
Thank you very much, ma'am. Any response? The comments are noted. Okay, yes.
Thank you very much, Madam Chair. Well, the first, we call her Presido, the first lady that just spoke actually mentioned one of the things I would have loved to say about the husband's income. The second one is that I want to know if Dr. Badru actually sought to know the educational status of these women. Because a yam seller in the market may not mind, going to a polygamous setting, polygynic setting that you pointed at. But as a lecturer or a professor, will mind. So I believe educational status should have been a correlate of this study to see how these two groups of women, react to such situation. Thank you very much.
Thank you very much, ma'am, for the right. So, any other comments? Dr. Badru, it looks like this study, you will be okay. Okay, let's hear you before we make further comments.
Thanks for the comments, Maz. Actually, monogamy was defined as a man that is legally married to one wife. But we don't actually know what is in their mind. It's what they tell us that we take. If you tell me you are the only wife of your husband, I won't probe further. So actually what mommy actually said is actually to may actually be in a polygamous setting, but now claim to be monogamous setting. Of course, we consider the economic status, the income of the man, the income of the woman, as well as level of education. But none of this was statistically significant in both settings. So that was why I just let it go. But now that they have mentioned it, I think I need more investigation. I need to do more investigation into that, ma. Thank you.
Thank you very much, Dr. Badru. Before you go away, I actually like to also know what was your sample size for each of these groups. How many women? I'm not sure I saw any reference to that. And so, based on the number, what actually were the percentages involved? Because it's not, enough to just look at the figures and say, oh, more women in this group than that group. You have to reduce them to percentages for you to have a proper perspective of what you have there.
There were 134 women in all, 67 in each of the groups. So we had 67 in polygyny, 67 in polygamy. So there were equal number of women in the same hospital with the same socioeconomic status, in the same set. Actually, it was a convenient sample of women that came for antenatal clinic. Okay,
let me allow. go ahead.
Thank you, Dr. Badru. I wanted to ask, you said social gatherings or socialization helped some of those women to cope. The ones who had more social engagements had less psychological problems. So my question is, what did you ask? What were the questions you asked there? So we know the kind of social gatherings to recommend. So I can just think it's the Owambe thing, or was it, what kind of questions did you ask there? And which ones, which of social gatherings actually helped? So we know what to recommend.
Thank you. Religious gatherings are different from social gatherings, though they may as well serve as social gatherings. But what they volunteered was that, though, going to parties, going to all these, there were no local women, all these Yoruba setting of Odebi, some things like that. But I want to say social participation, maybe clubbing, hanging out with friends. But women in that kind of setting, they don't know. Most of them, they don't actually go clubbing. It's just hanging out with friends, ceremonies. Those were the participation in social gatherings that they volunteered, which is quite different from participation in attendance of religious, at religious settings. But the two at times are used interchangeably. But in my settings for just clubbing, hanging out, relaxation, ODB, stuff like that. Thank you.
Thank you very much. Any other questions? It's evident that this particular study needs to be done, and the several confounders that have been identified need to be controlled for so that we can have a clearer picture. And that is the beauty of research. I guess in everybody else's mind, including my own mind, initially I would have thought, oh, the monogamous ones would have been happier than the polygamous ones. But that's what research is all about. So if we do a research properly controlling for all those other factors, and we come up with those answers, then we need to step back and see if there's anything. Maybe we do we adopt polygyny as a place to be happy in? All right then. So that's an aside. Thank you very much. Oh, great. Any other comments for other presenters? I think we have Dr. Nafisat Tijani online. She says she's ready to give her presentation. Can we quickly listen to her before we round up? Dr. Nafisat, are you ready to talk to us online?
Yes, ma, I am.
Okay, right. We also have Dr. Utulu online. Please, Dr. Utulu, get ready to quickly talk to us. I'm going to give each of you 7 minutes. Whatever you're going to say in 7 minutes each, so, because we expected you for the previous session and we waited for you. You didn't show up. So in 7 minutes, you speak to us. Dr. Nafisa Tijani is, you ready?
Yes, ma, I am.
Okay, please go ahead.
Okay. Good afternoon. My name is Dr. Tijani Nafisat Abdullahi. I am a senior registrar at the Department of Community Medicine, Amin Kano Teaching Hospital, Kano State. On behalf of my co-authors, I will take us through the abstract of our research, which is titled Availability and Quality of Emergency Obstetric Care Services in Primary Health Care Centers in Kano Metropolis, under the following outline. Background, next slide please. Background and objective, methods, results, and conclusion. As a background, maternal mortality remains a public health challenge in Nigeria, despite the policies and strategies to reverse this. 112 per thousand live births men and 1 in 34 women in Nigeria will have a death related to maternal causes. Evidence have shown that the major causes of this maternal mortality in Nigeria can be prevented if good quality obstetric care services are made available. And these emergency obstetric care services could either be basic or comprehensive. The basic obstetric care services are the administration of antibiotics, oxytocics, anticonvulsants, manual removal of placenta, removal of retained products of conception, and assisted vaginal delivery, while the comprehensive include this in addition to blood transfusion and cesarean section. Our study assessed the availability and quality of basic emergency obstetric care services in primary health care centers in Kano metropolis, which serve as the first level of contact with individuals with the health system. The methodology. Our study was a cross-sectional study design, and we assessed 30 primary health care centers. Data was collected using an adapted, structured, interviewer-administered questionnaire, and the data was analyzed using IBM SPSS statistics software version 20. The finding of our study showed that Kano metropolis fell below the accepted standard for the number of basic emergency obstetric care facilities and the facilities required for the available population, which is 4 basic emergency obstetric care facilities per 5,000 population. And most of the health facilities studied did not provide emergency obstetric care services for 24 hours a day and 7 days a week. And none of the primary healthcare facilities qualified as a basic emergency obstetric care facility according to the United Nations standard. Drugs, including parenteral antibiotics and oxytocics, equipment and supplies necessary for basic emergency obstetric care services were found to be adequate. However, parenteral anticonvulsants, antihypertensives, and items necessary for assisted vaginal delivery and removal of retained products of conception were found to be grossly inadequate. Likewise, there was a critical shortage of skilled birth attendants. In conclusion, our study provides useful information on the state of basic emergency obstetric care services provided in primary health care centers in Kano metropolis. And there is need for strengthening of the primary health care system so as to improve the services and ultimately reduce morbidity and mortality among women of childbearing age. Thank you very much for listening.
Thank you very much, Dr. Nafisa Tijani, for that, for keeping well within time. Thank you so much. So we'll go ahead to take the second presentation from Ronald Utulu. Ronald, if you're ready, if you're with us, can you? He's going to talk to us on probable risk factors for SARS-CoV-2, infection and disease severity, comparison males and females in Nigeria. You have the floor.
I want to know if you can see my slide.
Yes, your slides are up. We can see it.
Good afternoon, everyone. I'll be presenting probable risk factors for SARS-CoV infection and disease severity, a comparison of male and females in Nigeria, on behalf of my co-authors. This is our outline, and I'll just move on to the introduction. The SARS-CoV-2 epidemic has been the most significant challenge of the 21st century. Nigeria recorded our first case on February 27, 2020. The country is currently experiencing the third wave of the pandemic. An understanding of the risk factors for the infection and disease severity were key to interrupting transmission, forming recommendations for vaccination prioritization. Despite the efforts in vaccine uptake, prevention and control measures are still recommended. This study aimed to identify probable risk factors for SARS-CoV-2 infection and disease severity comparing males and females in Nigeria. Now, study area, the study was conducted in 6 states in each geopolitical zone of the country using a 1-to-2 unmatched case control study design. Cases were defined as people who tested positive for SARS-CoV-2 infection using reverse transcriptase polymerase chain reaction, RT-PCR. And controls were contacts of confirmed cases that tested negative on RT-PCR. Now, in order to identify risk factors for disease severity, we classified cases into severe and non-severe. Severe cases were those with difficulty in breathing requiring hospitalization, respiratory support with intranasal oxygen, a ventilator, ICU admission, or died from complications of COVID. We used the multi-stage sampling technique to recruit participants into the study. And the source of our data was from the NCDC SOMAS online database. All cases occurring from March to July 2020 were extracted. Data collection was via phone calls made to participants by trained research assistants. And for analysis, regression analysis was used to identify the risk factors for the infection and disease severity, with the level of significance being set at 0.05. Ethical approval was granted by the Institutional Review Board of the Nigerian Institute of Medical Research in Lagos. For our results, there were a total of 497 cases to 994 controls. Median age of cases was 34 versus 36 years for controls. Now, the rest is a summary of our findings, which I would speak more on the succeeding slide. For females, the risk factors for SARS-CoV-2 infection at bivariate analysis were contact with a symptomatic case, which was associated with an increased odds of infection and use of a face mask. But after multivariate regression analysis, only contact with the symptomatic case was significant. For males, diabetes, mask gathering, contact with symptomatic case, and use of a face mask were identified, had p-values less than 0.2, with diabetes, contact with the symptomatic case, and use of face mask being significant. After multivariate regression analysis, only mask gathering, attendance at mask gathering, contact with the symptomatic case, and use of a face mask were significant, with use of a face mask associated with a lower risk of infection. Now, for risk factors for disease severity, at the bivariate analysis, age over 50 years, hypertension and diabetes were significant for females. But after multivariate regression, only diabetes was a significant risk factor for increased disease severity among females. For males aged over 50 years, hypertension and diabetes were significant both after bivariate analysis and after multivariate analysis. Now, our discussion. Some studies have identified differences in infection rates based on sex. Most studies agree on increased severity of infection among males. Now, some of the factors that have been attributed to these differences include differences in immune response, hormonal sex hormone differences, behavioral and lifestyle factors. This increased severity among males may also be due to the increased proportion of comorbidities. In conclusion, the differential in risk factors by sex highlights a target for SARS-CoV-2 prevention, contact with symptomatic patients, supports isolation currently practiced to limit the spread. The need for those with comorbidity, especially in males, to have protection is also highlighted by this research. Thank you for listening.
Thank you very much. Another round of applause for him, please. I think that should be the only male that has presented. I'm right. We are, so far at least, we appreciate it. Yes, indeed. Somebody says you're blessed amongst women. Great. Fantastic. All right, so we will take a summary right now from the rapporteur. She's going to give us a summary of the two presentations, and then we'll go right to questions and comments.
Thank you, Madam Chair. The first presentation was on the availability and quality of basic emergency obstetric care services in primary health care centers in Kano Metropolis. The presenter was Dr. Tijani Nafisat. She gave a background that maternal mortality is a public health challenge despite policies and strategies to reverse it, and there was need for good availability of good obstetric care. This study was done in Kano Metropolis. She did a cross-sectional study of 30 primary health care centers, and it was administered questionnaire. The results, she said the Kano metropolis fell way below standards, had 4 basic emergency centers per 500,000 people, which should have been per 5,000. And the facilities lacked power and 24 hours, they were not 24 hours or 7 days per week. Drugs supplies were adequate, but antihypertensives, anticonvulsants, and other assisted birth facilities were not available. There was such shortage of skilled birth attendants. So in conclusion, she said there is a need for strengthening the maternal health care and primary health care centers in Kano State. The second presentation was on the probable risk factors for SARS-CoV-2, a comparison of males and females in Nigeria. The presenter was Dr. Utulu R. Introduction, he said the SARS-CoV-2 pandemic was a significant challenge of the 21st century, and in Nigeria we had the first case on February 27, 2020, and we're currently in the 3rd wave. The aim of this study was to identify the risk among males and females, and also severity. The methods. The study was done in 6 states, 1 in each geopolitical zone in Nigeria, and was a 1 to 2 unmatched case control study. The study used the polymerase chain reaction confirmation of SARS-CoV-2. The data was collected by phone calls to positive patients by research assistants. The results, there were 497 cases with 994 controls. In females, the risk factors that were identified were contact with a symptomatic case, use of face mask, and in males, risk factors were diabetes mellitus, large gatherings, significant contact with a symptomatic case, and use of face mask. The significant risk factors after the data was analyzed was large gatherings, contact in males, while female was contact with a symptomatic case. The use of face masks was found to lower the risk of infection. Also in females, age greater than 50, hypertension, diabetes mellitus were also found to be significant, but diabetes mellitus was the most significant. In male, hypertension, diabetes, most significant risk factor, and also indication for severity. And in conclusion, it found increased severity among males and also increased proportion of comorbidities among males. So in conclusion, this study has found targets for SARS-CoV-2 prevention by targeting the people more at risk. Thank you.
Thank you very much. I think you deserve a round of applause too. Yes. Okay. So we will take questions and comments at this time. Those online to raise a digital hand if you want to partake. Any questions, any comments? Yes, ma'am.
Good afternoon, everybody. My name is Dumevi Owa. Please, I'd like to know what we need to do as a group or as individuals to help strengthen the primary healthcare center and reproductive healthcare system in Kano State. Because from that research, what they have there is appalling. So as a force to reckon with, M1 as a force to reckon with. What do we need to do to help? Apart from advocacy, what else do we need to do to help? Because those women are our sisters. In this 21st century, it's crazy to have such facilities there. Thank you.
That's a good topic for discussion.
The chair.
Yes.
I'm glad you made the comments. My comments were going to be like this. You present, Dr. Badru, right? You presented this to MWAN 2021. I'm hoping that our biennial in 2023, you give us a follow-up to say that this is the intervention that you have worked on with results. I think MD can, beg your pardon, M1 in your state, we are appealing to them to support you to implement an intervention program so that we can have changes. Thank you. As for the COVID, infected females seeming to fare better, I think women fare better in some disorders. I will use sickle cell anemia, for instance. The females live longer than the males. So I will ask our presenter, is there a specific immunological study that has been done to show why females do better when infected by COVID-19? I will just cite one immunological parameter that we can look into, the natural killer cells. If my memory serves me right, I think women have a higher level of NK cells. So the presenter can choose any immunological parameter that can help us to understand why we do better. Though I don't wish any of us should get infected. Thank you.
Thank you very much. Okay, so you have gotten a new research topic from this meeting. It's part of mentorship, Abima. It's part of mentorship, yes. So you'll be mentored today. One day mentorship here. Right. Okay, any other questions or comments? Okay. The presenters online too, please feel free to respond to any of the comments or questions that are relevant to you. Okay, I have a hand at the back. Well, towards the front here. Welcome, ma'am.
Thank you, Madam Chair. Mine is a comment. I think that some of the presentations we have made here today are very effective advocacy tools that we can use. Looking particularly at the Kano case, this is a report that can be used to speak to the people in power and to show them that when things are done differently, that the outcome is also visible. So we shouldn't just do studies, share the information among ourselves. We should use them as political tools to advocate. When you show people visible results of what is happening in their environment, I think sometimes it pushes them to do better than what they've done before.
Thank you very much, ma'am. That's a very valid point. So M1 has a lot of resources to draw from as we go about our advocacy exercises. Thank you very much. Any response from the online presenters? Does anybody want to respond to any of the comments or questions? Okay.
Okay.
Yes, okay.
Okay. Who's going first?
Ladies first.
All righty. Dr. Nafisat.
Okay. Thank you very much, Ma. Thank you very much for the question and the comment. I'd like to respond by saying primary health care is one of the strategies to achieve the universal health coverage, meaning that it should be strengthened. And the aim of every research is not just for it to improve or to contribute to the body of knowledge. It should contribute to policy as well as to contribute to improvement in our practice. And as part of our study, an advocacy was paid. And the aim of the advocacy is to relate the status of our primary health care, the status of our primary health care in Kano Metropolis. What is going to be done goes beyond the level of individual level. It should be a collective effort of the government as well as the individuals. That is why community participation is a strong pillar in primary health care. As such, in political will, there is need to make resources available, and resources in all ramifications. The issue of money, the issue of manpower, that is the most important. If you can see all those signal functions, in addition to them not being available, which would be served by procuring them, improve political will, there is need to also procure staff that are skilled birth attendants, particularly the midwives, especially since it's in a primary health care facility, and collective and continued training and retraining of those staff. So it will interest us to know that in Kano State, these strategies have been put in place as there is an ongoing employment of medical officers of health who are supposed to be the custodians of all local government areas. And by that way, it's going to improve the practice of primary health care. There is also the training of midwives under the Saving 1 Million Lives, which is a program for action. We should also do, as individuals in the community participation is very, very important. Every program that is done without contacting the members of the community is bound to fail. So our advocacy should not be limited to government only. We should make effort to also involve the community so that they will take ownership of their health. In this way, we'll go a long way in improving the status of our primary health care services and the status of our population as a whole. Thank you very much.
Thank you so much. And so M1, I think, rising from this meeting, we are charging M1 Kano, Chairman M1 Kano, to liaise with the National President M1 to see what we can do about the situation in Kano. I'll allow Mr. Roland to speak before we have somebody else. Mr. Roland, please.
Okay. Thank you, ma'am.
Or is it Dr. Roland? I beg your pardon.
Question.
Yes.
It's okay, ma'am. Thank you for the question. I did not come across a particular study. I came across a number of studies on immunology and other things. And what they cited were mostly the proliferation of sex hormones. Now, in order not to get too technical, a lot of them were heavy, very technical immunologic studies that the much I could glean from them was that they talked about the proliferation of ACE receptors, angiotensin converting receptors. They also highlighted, but for most studies, there were no real agreements on the major factors. But some studies found a difference, some other studies did not find a difference. But the major factor that most studies agreed upon were that the males had, it was dealing with viral infections, and it's just been seen over time. There was no particular reason for that. And then they talked about the higher prevalence of comorbidities among males being the main factor, because it's seen that people have worse infections. Those who have comorbidities have worse infections. So that was the main reason cited in most of the studies. The particular immune receptors or all of that was, there were different views. But the major thing I saw in multiple studies had to do with the ACE receptors. So that's the much of my expertise. Yes, thank you.
Thank you very much. It seems the men have more risky behavior. There's one man standing right across from me who has his mask down. So can you please put up your mask? Yes. Because, of course, the viral load you get is also very significant towards coming down with the infection and how severe it will be. So, Dr. That the men have more risk behavior. I can attest to that. Since last year, each time we went for NMA program, national program, they hardly wore face mask. Very disgraceful. I had to stand at the entrance to enforce no face mask, no entry. And I didn't have to do it here. All the women here understood what to do, and they did it. So it's very obvious, even among the doctors, the male have more risky behavior. Thank you. That was an evidence-based study. We had one man or two right here doing that. Thank you so much. All righty. So I think we are gradually coming to the close of these 2 sessions, 2-in-1 sessions. And we want to thank everybody who has waited patiently up to this time. I think we'll be having announcements. Permit me to recognize my chairman, my president, M1, acting president, M1 Lagos State. Ma'am, I recognize you so that when I go back to Lagos State, they wouldn't cane me, so I must recognize. Yes. And I must also recognize the elders from Lagos State. We have Her Excellency here, Dr. Akweme. Ma'am, thank you for being here. We also have other past presidents and very senior members. Dr. Esangwedo, ma'am. Dr. Dabiri, ma'am. Dr. Dumemi Owa. Dr. Sherarije, all of them past presidents, M1 Lagos State. I must recognize you and your presence here. Dr. Amaomi Bakari. I mustn't miss out any name so that I don't get caned at the gateway to Lagos. Okay, I'm also told that we have Dr. Belgan from Rivers, who's also present here. Permit me, if I have left any name out, I'll leave the MC to recognize the rest of the president. The president-elect. Oh, welcome, ma'am. President-elect has joined us at the table. You're very welcome, ma'am. Thank you.
The chairman of this session, the rapporteurs, the entire House, I wish to say a big thank you on behalf of the national president, who is on the way. It has been a very exciting session, a lot of collaborating and networking. This is what we expect of M1, and I'm happy that all of you have waited so long since morning. I'm sure it's going to be a very successful biennial conference. Thank you very much for coming. I recognize everybody, all the professors, all the heads of departments, all our elders, all the past presidents, the national and the states. You are all welcome, and I thank you very much. And I'm indeed very happy to see all the YDF, my supporters. God bless you. Thank you very much. The presenters, please, it appears that you want to force me to talk, but I don't want to talk now because we had an outreach in one of the rural areas of Ibadan. It's exactly like the situation in Kano. And many of you, when you see the videotapes, you know that things are happening in Nigeria. A PAC center whereby 4 men have to carry pregnant women into the PHC center to deliver. This PHC, they have minimum of 45 deliveries per month and over 130 patients per week for antenatal care. Again, they have 150 children that attend the clinic every week. What is government doing? What is MWAN doing? Let us remember the founding mothers. They mentioned it that the government could not do it all, and as such, they came in. So MWAN, let us be well equipped, let us be ready to do the needful, particularly with this pandemic. It has shown us that the medical infrastructure is very weak. So let the next tenure, the next 2023 biennium, have a different story to tell. Thank you very much. Thank you.
Thank you very much, Madam
Thank you.
NPE.
All right. On that note, I hand over to the...
Thank you, Ma. So I would like you to, once again, please put your hands together for Dr. Chioma Umesi for the wonderful job that she has done, and also for Dr. Tema Akpabio. Please put your hands together for them. So in rounding up, I would want to once again appreciate the chairs for today's sessions in the persons of Professor Omokodion, Professor Galadenchi, Professor Wura Olashokumbi, Dr. Ijeru Olukumi, and Dr. Dona Umesi. I also want to thank all discussants on the panel of discussion on mentorship. I want to thank all the capable rapporteurs, the presenters that were physically present and those who presented remotely, all delegates here present and those who were in attendance online. We will close now and reconvene at 6 p.m. at the foyer of the Otumba Shubomi Balogun Conference Center in University of Ibadan for a welcome cocktail. Thank you very much once again.